Good evening, everybody. Welcome to Prostate Forum. I'm Neil Burke. I'm the CEO, and we're delighted to have, for his very first time here, Professor Osama Mohamad MD from the University of San Francisco in California. We're particularly excited to be having the doctor for our friends up in the Central and Northern California area, Oregon area, Idaho, where accessing UCSF medicine might be easier for you than coming down to Southern California. Tonight's presentation is called The Practical Approach to Radiation Options for Prostate Cancer. We're going to talk a little bit about some of the new things going on. Okay, presentations are just a little bit of what we do if you're new here. We have a newly diagnosed group. That is also our active surveillance group. And that meets every second Tuesday of every month at 5 p.m. Pacific to 7 p.m. Pacific. There's a Zoom link. Make sure you sign up with us on our Join Us page on our website. That way we can get you into our email blasts. We also have an advanced recurrent group that meets every fourth Tuesday of every month at 5 p.m. Pacific. There's the link right there. We don't give medical advice, but we do share our experiences. And we're delighted to have these groups moderated by Dr. Charles Metzger, a urologist of more than 30 years, and Ira Caggett, who is very learned on the subject of prostate. You can also find our videos of past presentations at prostateforum.org presentations. We need your help. Contact us to volunteer. You can email us at prostateforumoc@gmail.com, and we will be delighted to talk to you about volunteering. Dr. Mohamad is an honors graduate at American University of Beirut in Beirut, Lebanon. He earned his MD and PhD at Emory University in Atlanta. He continues training and research at the University of Hawaii, the University of Texas Southwestern Medical Center in Dallas, and is a research fellow at the National Institute of Radiological Sciences in Japan, studying carbon ion radiotherapy for prostate cancer. His awards including the Resident of the Year Award and RSNA Roentgen Research Award during his chief resident year at University of Texas. He's presented his research at multiple national and international meetings and has over 45 publications. Without further ado, I am going to welcome Dr. Osama Mohamad.
Thank you so much for having me today. It's really a pleasure. So I don't have a lot of slides. I only have 5 slides. I've participated in so many support groups, and I feel over like the last couple of years, I feel the best format would be that I just tell you how radiation oncologists usually think about cases when they come through the door. And also, you know, I know each one of you have been through the treatment processes, most of you, and, you know, I'm sure like lots of you have lots of questions. I'm happy to go over questions and cases and what's going on with you guys. I'm extremely happy to go over. Please interrupt me anytime. Again, I only have a few slides, so I can show you a little bit and then we can talk whatever you want to talk about for the rest of the time. So I'm a radiation oncologist, and what it means is that I treat prostate cancer with radiation. Typically, anytime you have a patient with any kind of cancer, there are several doctors who are usually involved in their treatment. Usually, the first doctor that would discover something in prostate cancer is usually the primary care physician when they are doing the PSA tests. And then the primary care physician would usually 99% of the time will send the patient to the urologist. And the urologist is a surgeon, and they will make their own assessment. And then usually depending on the kind of cancer, the referrals go to the medical oncologist who does the chemotherapy and the hormone therapy, and also can go to the radiation doctor who does the radiation therapy. But behind the scenes, in addition to the urologist and the medical oncologist and the radiation oncologist, behind the scenes, there are like a pathologist who usually takes a look at the biopsy slides that were taken during biopsy, and also radiologist who's looking at the MRI and the PET scan and the ultrasound to help make the diagnosis. Now, whenever I get a patient through the door with prostate cancer, we usually look at many different things to evaluate each patient, because it's extremely rare to have two patients with exactly the same thing, because there are so many variables, and each of these variables will get into the decision making. Let me give you an example. Let's start like here. I try to list all the possible variables that I think about whenever I see a patient. So let's say a patient walk in, and the patient is 85 years old with prostate cancer. And let's say another patient is 60 years old with prostate cancer, assuming that the 85-year-old and the 60-year-old have exactly the same PSA, exactly the same biopsy results, exactly the same MRI results. Our approach to treating a 60-year-old patient is completely different sometimes than our approach to treat 85-year-old patients. What I'm thinking is that a 60-year-old person have on average about 20 years of life, and 85 years old patients have on average about 10 years or less of life. So what we offer in terms of treatment is different. We may be more aggressive in a 60-year-old man, like giving them, for example, hormone therapy if hormone therapy is needed, giving them more aggressive radiation therapy. Usually a patient in their 80s don't get surgery for prostate cancer. Usually it's treated with radiation, if at all treated. Now, in addition to the age, of course, comorbidities. Like comorbidities mean the other medical conditions that the patient have. For example, patients who have cardiac disease, especially if they have a recent myocardial infarction in the last 6 months, these patients, we should be very careful in giving them hormonal therapy, for example. If a patient is 70 years old versus a patient and his family lives to the 90s and 100, this is a very important consideration, how long the family lives. Also, do they have autoimmune diseases? Because if they have autoimmune diseases or Crohn's disease or ulcerative colitis, which are diseases of the colon, where the immune system attacks the colon and the rectum, we have to be careful, for example, with radiation. And also an important consideration, did the patient get prior radiation for rectal cancer or prostate cancer? Also, another consideration is like how functional the patient is. Are they a 90 years old, but they are extremely functional, or are they a 60-year-old person, but they have lots of comorbidities and lots of issues? Also, very, very important, what is the PSA level? What is the T stage, which I'll explain to you in a second, which is basically when the doctor does a finger exam, or when we do an MRI or we do an ultrasound, we can tell the T stage, which is how far did the cancer go outside the prostate? Is it enclosed within the prostate, or did it go through the capsule, or did it go to the seminal vesicles? And also the pathology Gleason score, which is how the cancer looks under the microscope. And there are many, many other considerations. I don't want to go into all the details, but also how big is the prostate, and how is the function of the urination, and how is the sexual function, and did we get an ultrasound, an MRI, and PET scan, and other genetic tests? Any questions so far?
Good.
Anybody would like to share their story? Newly diagnosed person would like to share their story? If they have any questions? Okay, I'll keep going for a little bit. So anytime, again, so I've told you all the factors that go into the decision making. Let's talk a little bit about some important things. And this is the T stage. Often you will, when you look at your report, the ultrasound or the MRI, you will look at things like the doctor will be saying T1A, T1B, T1C, T2A, T2B, T2C, T3A, T3B, T4. What do these designations mean? Again, these designations mean how far did the cancer spread in the prostate and in the pelvis. For example, if the cancer is not seen on MRI or ultrasound and not felt on finger exam, we say T1. If the cancer, you can feel it with a finger exam, but it remains within the prostate, we say T2. And there is T2A if it's in one part of the prostate, T2B in more than one part of the prostate. T3, it's becoming an aggressive cancer. This is when the cancer goes through the capsule. T3A went through the capsule, T3B went into the seminal vesicles. And as you can see, as the numbers increase from T1 to T2 to T3, this is a more aggressive designation. T4 is when the cancer goes and invades into the bladder or in the rectum. So as you can see, these are very important things. And the more the T stage, the higher the T stage, the more likely the patient will need additional treatment, extra treatment. But also in terms of like progression or where the cancer is, we are not only interested in the cancer in the prostate, but also we're interested if it went to the lymph nodes. So if we designate the lymph node by N, N0, there is no cancer in the lymph node, and 1, the cancer has left and is outside the prostate in the lymph nodes. And again, N1 is considered an aggressive disease compared to N0. And again, not only in the lymph node, is the cancer in the bone. And this is, we can see it on PET scan, bone scan, CT scan, or PET scan. And now we talk about M0, no cancer in the bone, or M1A, cancer in the bone or in the lymph nodes outside the pelvis. Now, after I see a patient and I have said, I know their PSA now, and I know the T stage, I know the N stage, I know the M stage, and I know the Gleason score on biopsy. So the biopsy was done and like somebody looked at it under the microscope. And I know the patient, their functional status, are they good function or are they poor function? And I know how they are doing, do they have other medical conditions? And I get a good assessment of their baseline urinary function and sexual function. Now I can start talking about giving treatment. Anybody has any questions?
Doctor, this is Brian McAvoy. I should explain that we normally tell people to wait with questions till the end. So I'm guessing that's what they're doing. So,
yes. But I
get nobody has questions. Okay. Okay.
Okay. We can wait till the end, of course. Okay. So now I have a full picture of what's going on. Now I am ready to make a decision. However, to make a decision, I'm going to show you one of the ways we classify patients into a certain category based on which we make the decision. Let me give you an example. So this is a very famous thing. You probably, if you have met with your doctors, you probably have seen this in the doctor's report, which is the risk group. We usually talk about a patient is low risk or very low risk or intermediate risk or high risk or very high risk. So how do we do this? We usually put the patient PSA, Gleason score, which is a biopsy report, or the T stage, which I just shared with you. And based on these 3 categories, we can say if the PSA is less than 10, the stage is T1 or less, and the Gleason score is 6, we say they are very low risk or low risk. And the more PSA, the more T stage, the more Gleason score, then we start putting the patient in higher and higher categories. And once I say patient is intermediate risk, in my head, I know what are the treatment options. I can tell you now, very low and low risk, we usually don't treat these patients. These are the patients that we say they can benefit from active surveillance. We just monitoring, no need for treatment. We will follow them up with PSA every 6 months, ultrasound or MRI every year, and then biopsy every 1 or 2 or 3 years, depending on the results of the other tests. If the patient is intermediate risk, we usually say, are they favorable intermediate risk or unfavorable intermediate risk? In the favorable intermediate risk category, they can get surgery or radiation without hormone therapy. Unfavorable intermediate risk, they are either surgery or hormone therapy plus short-term hormone therapy plus radiation therapy. And now finally, if the patient is high risk or very high risk, they're usually needing surgery with possibly needing radiation therapy after the surgery, or they needing radiation upfront with long-term hormone therapy, 12 months, 18 months, 24 months. So as you can see, doctors like to do these categories because it makes decision-making much easier. Now that I told you how we think about patients and how we categorize patients and the risk of the patients, let me tell you a little bit about the different kinds of radiation therapy. So I created this small graph, and as you can see, radiation therapy for prostate cancer in big categories is 3 big categories. External beam radiation therapy is the biggest category, and this is, as it said, the radiation comes from outside, external beam. And the next most common one is the internal beam radiation, which is also called seed radiation, also called brachytherapy, also called interventional radiation. And this is when we put radioactive seeds inside the prostate. And the third most common, but it's not as common as the other two, and probably a lot of you have heard of this recently, is the injectable radiation. This is when we inject a material in the body, and that material will go throughout the blood and invade the cancer wherever it is. Okay, let's talk about the external beam. Within external beam, there are 2 big families. There is the photon radiation, which is most of the delivered radiation, and there is the particle radiation. The photon radiation, I'll show you a little bit, there are different kinds. Most of you, whenever I see patients, ask me, are you going to give me IMRT treatment? Very common. The particle radiation therapy, this is when we use not photons, when we use actual particles such as protons, or not present in the United States at the moment, carbon ions or helium. Now, the other family is the seed radiation or the brachytherapy. There are 2 types: low dose rate brachytherapy or high dose rate brachytherapy. Low dose rate brachytherapy is when we put the seeds inside the prostate and the seed stays inside forever. They deliver radiation slowly over the next few weeks or a couple months, and then they are no longer active after a few months, but the seeds stay in there forever. The high dose rate brachytherapy is when we put the seeds, we put catheters in the prostate through the perineum, and the seed will come into the prostate, deliver radiation through the catheter, and then it comes out. And it keeps doing this until it goes throughout all the catheters. Finally, the radionuclides, just the older one, radium, is not as commonly used now. And lutetium is like a lot of the hype over the past year is over lutetium PSMA. And finally, this is the last slide, and then we can have a chat. So finally, I just want to show you something very important so that you can get some understanding over what is radiation therapy. So, and this axis is the timeline from 1935 till like the early 2000s. And what this is this is a CT scan. This is a cut of the CT scan at the level of the prostate. The prostate is here. This is the rectum, and this is the lower part of the bladder, and these are the hips. And what this is trying to show you how the technology for radiation has progressed over the last 70, 80 years. Let me explain. Gray is the unit of radiation. The first important thing to tell you is in 1935, the radiation techniques were so primitive, we were only able to deliver 40 gray of radiation, very low dose. It does not treat cancer at all. Now, in 2010, we can give 2005, 84 and 100 gray. So you can see our ability to deliver doses have significantly increased over the past 100 years. But it's not only that we are able to deliver more dose, we are able to deliver more dose while protecting the normal tissue around the prostate. Let me explain what this means. You see, the highest radiation dose in each of these figures is in red. So you see here, the more modern radiation. The red is surrounding the whole prostate, but you see how it's very nicely carved around the rectum. This is the rectum. So we are able to deliver extremely high doses of radiation to the prostate without damaging the rectum. And most of the tissue around the prostate has been spared. You see, there is no radiation around it. But if you go back to the early 30s or 40s or 50s or 60s, you see, although we are delivering radiation dose to the prostate, but a lot of the tissues around the prostate were getting also irradiated. And as time passes, you see, look, here the red is in the prostate and the yellow is in the rectum. You see, as time passes, we are able to give more dose to the prostate and more protection over the rectum. And as time goes by, it's even more protection of the rectum. So all of these different kinds of radiation, the older radiation techniques which we never use, like the 2D radiation or the cobalt radiation, compared to the more modern radiation such as IMRT, compared to the particle therapy such as carbons or protons, we have been able to deliver more dose with more protection to the normal tissues around it. All of these, whether IMRT or carbon, this is all external beam radiation. You see the radiation coming from outside the body into the prostate. And finally, I want to show you the setup for brachytherapy. So this is a typical setup for brachytherapy. The patient would be on their back, the legs are up, there is an ultrasound in the rectum, and through the perineum under the scrotum, you put needles to put seeds inside the prostate. Again, this is a permanent seed placement, or the LDR, a different technique. Instead of putting the seeds directly, you would put catheters through the perineum, usually 16 or 14 catheters in the prostate, and the seed will come in and out through these catheters until all the radiation is delivered, and at the end, the seeds stay in the clinic and the patient goes home without radioactivity. Okay, these are all the slides. I just wanted to do the slides as an introduction to radiation, and the rest of the time, I just want to talk to you. Anybody who have questions, want to share their story, I'm happy to answer. Or what's going on with you guys now? Anything that's going on, we can talk about it as well.
I have 2 questions for you, Doctor.
Let's go.
I'm curious of why you said it's hype with LU-177.
I did not say it in a negative way. I did not say it's hype in a negative way at all. But usually we know in medicine in the beginning, everybody is very, very excited. So lots of things. And then times goes by, we discover that we discover something else and we move on from that thing to something else. I did not say it in any negative way at all.
I want to give you a positive vote for LU-177. I've been to Zentralink, had 2 treatments.
Oh, nice.
Yes, thank you. Very good.
And
my second, I'm sorry?
How is it going?
I have no cancer visible.
Nice, very great.
So I'm sensitive one LU-177, especially what Provicto has done with it in the US. So not politics I can get into, but the second question I was asked, in your slide, you showed the higher numbers. What is your success rate with the higher numbers using radiation?
Well, it's, as you know, it's difficult to answer this question because, what kind of cancer are we talking about? Are we talking about early stage cancer or advanced stage cancer, or is it cancer in the lymph nodes, or cancer in the bone? So it's difficult to answer the question for the success. If you give me a particular scenario, I'm happy to answer.
I would say let's go early stages. The metastasization is 2 spots, very minor.
Well, when the cancer has spread outside the prostate in the bone, if you are, I'm assuming you say metastasis, so it's in the bone, it's an incurable disease. Now, whether or not we can achieve a long-term durable control, and in the next few years or in the next decade, we're going to get to a point where going to see patients 10 years and 20 years without evidence of disease. I think this is extremely possible. And we are very hopeful that the future is going to hold that, at least even with bone mets, we are going to get to a point where we are going to keep these patients for a long time without evidence of disease. I'm very confident of that. But at this moment, we should talk about these conditions as incurable, because the data is still at that level.
Thank you, doctor.
You're welcome.
Doctor, can you hear me?
Yes.
Okay, I had a radiation done about a year ago, about 2 years ago.
Okay.
And now currently I'm bleeding. Is
Okay.
there something that was done incorrectly during the radiation?
Yeah.
Or what I can do to mitigate the bleeding?
Yeah, let me ask you some questions. First of all, do you know how aggressive the cancer was?
Well, it jumped up from PSA of 7, and they jumped up to 9.
Okay.
And so, I mean, I had consulted with the radiation prior to that. After 1 year, after I had diagnosed with the prostate, and she suggested radiation, but I put it off for about another year, and then I had it done. And when the PSA jumped.
Okay. And do you know what was your Gleason score on the biopsy?
7.
7. So, and you got radiation without hormone therapy.
Right.
And do you know how many treatments with radiation you got?
About 30 or 30, something like that.
Okay. So honestly, and let me ask you, how often is your bleeding happening?
It's happening. I mean, in the beginning, it was not bleeding, and now it's bleeding almost every day. And
Yeah.
I was given suppositories, mesalamine suppositories, and but it really didn't cure it. In fact, it was just, coagulating, instead of coming in like a free watery. You know what I'm saying?
And let me ask you, let me just confirm, are you bleeding from the in the urine or in the rectum?
Rectum.
In the rectum. Have they done a colonoscopy?
Well, I had not a full colonoscopy, but
yeah,
not a full colonoscopy, but I had a colonoscopy,
yeah, I know what you mean.
And I had it checked by, in fact, his name was, I'm trying to remember the name of the doctor, Embiid, Dr. Embiid. His name is EMBIAID here in Orange County. And he suggested it to treat it with laser treatment. And I haven't done that yet.
Yeah. So actually, honestly, like, are you on a blood thinner?
On the blood center, no.
Yeah, honestly, like radiation damage from radiation to cause rectal bleeding, and where you can see that there is a bleeder that requires treatment is actually very rare. It's probably around 2 to 3%. And you know, the treatment for that condition is actually it's a little bit complex, the treatment, but most of the time, if there is a bleeder, a laser treatment, like your doctor is saying, should be able to take care of it.
Well, you know, I went to the first doctor, and he says, no, you're just a small bleeding. You shouldn't even worry about it.
Yeah, I mean, if it's a little bit bleeding here and there, that is not common, and it's very small, and every now and then, yes, you should not do anything for it. But if you are bleeding very commonly and eventually your blood count will drop, then you probably need to do something about it.
Well, that's why my primary physician, because I started bleeding almost regularly, and he was a little worried about being that I was what do you call it? That I was losing a lot of blood.
Yeah.
But my question to you is, what kind of treatment I should get to stop that bleeding?
I mean, there is nothing you can do, honestly, in terms of like food or anything you can do to stop it, other if the bleeding is there, and if there. So what happens with the radiation, if this is a rectum radiation, will cause damage to the wall of touching the prostate. And the prostate, because the prostate and the rectum are wall-to-wall like this. So if the radiation causes damage to the anterior rectal wall, then you will be bleeding, because usually there are blood vessels there. If that area is damaged, the blood vessels are exposed and you are bleeding, because poop is going through all the time, and there's bacteria, and it does not heal. So the only, if the bleeding does not stop and there is a visible vessel, I think the laser treatment should be very helpful.
You mean I should get another laser treatment?
Have you had one?
Well, when you say laser, oh, okay. No, I had radiation done, not laser.
Yes. And Dr. Metzger was talking about the rectal gel. So in theory, so people were saying, okay, if the rectum and the prostate are wall-to-wall like this, and we know that radiation is causing damage to the rectum, so why don't we put a gel between the prostate and the rectum to push the rectum out of the way? We create a space and we can treat the prostate without damaging the rectum. Well, they did a study with this, and they've noticed that while putting the gel improves the tolerance of radiation, decrease the side effects from radiation, it did not decrease the risk of rectal bleeding. So we are still not sure if it helps with the rectal bleeding.
Well, what do you mean by putting the gel?
So the train have left your station, so there is nothing you can do at the moment. But for patients who are planning to get on the treatment now, so they have not received the radiation yet. So sometimes before the radiation, somebody would go through the perineum, put a needle between the prostate and the rectum, and insert the gel to push the rectum out of the way. Yes, it's called spacer.
Well, I think they put some spacer, but not. Yeah, I read about that spacer.
Yeah.
So you have to put the spacer every time?
No, we don't put it every time. Again, with the studies, did not see a lot of benefit. So I don't use it very commonly unless I'm doing like patients that I use it in are those who have, for example, Crohn's disease or ulcerative colitis. So we know the rectum is so sensitive. These are the patients that I use it with. Or when I do SBRT, SBRT is very high dose of radiation. So when I do these high doses of radiation, I use spacer, but not for the IMRT, which I assume is what you got.
Right.
Yeah.
Well, you know, I have had a hemorrhoid pulse operation about 30 years prior to that. I had a hemorrhoid problem, but when I had the radiation done, I did not have any hemorrhoid problem.
Yeah. Now, radiation can aggravate the hemorrhoid issues, but if your GI doctor who did the scope is telling you there is a bleeder, this is not hemorrhoid. Because he or she can tell the difference actually.
Right. So he's suggesting a laser treatment.
If this is what he says and you are bleeding, if you are not bleeding a lot, it's not affecting you, I don't think you should do anything. But if you're bleeding a lot and you have done all the other therapies like the enemas and the suppositories and all these things, then if you don't have options.
Okay, thank you.
You are very welcome. I want to answer one question in the chat. Does having a hip replacement affect radiation treatment? It does affect, but not a lot. Let me tell you why. Maybe I can show you the screen because it's very useful to show you the screen. So let's go back to this. Can you guys see this? Most patients are getting IMRT like this. You see this, what I'm showing here? It says IMRT, right?
Yes.
You see my okay. So you see this is the prostate is here, and these are the hips. This one is the hip. You can see them here. You see these are the hip bones. So typically when we do IMRT or SBRT, the radiation beams come from all angles, including through the hips. Now, if a patient have one hip replacement or two hip replacement, there is metal in these areas. We really don't like radiation to go through metal. So if a patient have hip replacement, we don't let the beams go through these angles. So this is one impact of hip replacement on radiation. The other impact of hip replacement is that when you have metal hips, one unilateral or bilateral, then MRIs or even CT scans, the visibility of the cancer on these can become difficult. So it may make the diagnosis and knowing where the exact prostate to draw the target a little bit more difficult. I hope this answers the question.
Yeah, Neil, I have a question. If I could jump in here, I got to congratulate you. You went 37 minutes without mentioning SBRT. Now,
yeah, we'll talk about SBRT.
All we hear about it in the land of UCLA, USC, you know,
yeah.
Okay, so can you help us figure out where that fits in and when you use it?
Yeah, of course.
You would use IMRT instead of,
yeah.
And you live in the land of Mac Roach and Shinohara and yeah, you know all the names. So oh my gosh.
Yeah. So let me, you guys, a lot of not only.
By the way, we both went to Emory.
Yes. I saw
you. 68. Yeah.
So
makes me ancient.
So SBRT, it only means that we are delivering high doses of radiation per treatment. So historically, and we're only SBRT, we're talking about external beam, we're not talking about brachytherapy. Historically, a long time ago, maybe 30, 40 years ago, we were not, because of the technology, we were not able to deliver high doses of radiation for every patient. So if we want to get to the 80 gray that I showed you, the dose, the high dose, we have to deliver a small dose per treatment, 2 gray. So if we want to get to 80 gray and we're delivering 2 gray per treatment, so we have to go over 40 treatments to get that full job done. Now, as time passes, we're able to deliver higher doses per treatment from 2 gray to 3 gray to 5 gray, and now we can give up to 8 or 9 gray per treatment. This dropped the number of treatments needed from 40 treatments to 5 treatments. Whenever we are delivering high doses per treatment, this is called SBRT. So patients who have early stage prostate cancer, the cancer is in the prostate, we don't need hormone therapy usually. We can do SBRT we don't need to do the 40 treatments. Now, patients who have very high risk prostate cancer, the Gleason score is 9 or 10 or 8, or the cancer went through the capsule, then for these patients, we actually cannot, usually, I don't want to say cannot, but SBRT or high dose per treatment is not the standard of care yet. And most patients with higher risk prostate cancer, more advanced prostate cancer, should not get SBRT only for these patients. However, you can combine SBRT with IMRT for these high risk patients, but SBRT alone is not standard of care.
Is the SBRT going to the prostate and the IMRT going to the pelvis, or?
No, the SBRT go to the prostate, the IMRT goes to the prostate and the pelvis.
And then how does that, how many IMRT sessions would you have then?
So SBRT usually 2 when you are doing the combo. SBRT 2, IMRT around, different people do differently, but at 25, 23, 25 is the most accepted.
And then where does proton
so
honestly, you have to buy equipment?
Yeah, proton is a way of delivering external beam, but instead of using X-ray, we use proton beams, basically a beam made of hydrogen ions. And in theory, in physics, and these experiments have shown that you can protect the normal tissues. You can deliver higher dose to the prostate and lower dose to the rectum and bladder. However, in practice, there have been no studies that have shown that protons is better than the regular radiation. It did not decrease side effects, and it did not improve outcomes or decrease recurrence for prostate cancer.
And it's more expensive.
And it's way more expensive.
How about with all of this business about precision MRI guided, why not just treat that PIRADS 5 or that PIRADS 4 or 5 and leave the rest of it alone, and even stay away from the rectum?
Yeah, absolutely. I mean, UCLA actually, since most of you guys are in that area, UCLA is...
Go Bruins, yeah. They're playing right now. They're in the NCAA Sweet 16. Good. They're not ahead right now, I hate to tell you. But,
so UCLA is doing lots of work with MRI guided radiation, meaning the radiation. Okay, let me tell you what is MRI. So typically all our work that we do, we use a CT scan to guide the radiation. And I don't know if you ever reviewed the CT scan with your doctor. CT scan does not really show, it's only 2 colors. You see white, 3 colors, white, gray, and black. So it does not tell you the fine differences and the anatomic variations of the prostate and the muscles and the rectum. But because it's not very accurate, sometimes when we draw our targets on the CT scan, it may cause our inability to really define where the prostate ends and where it starts. When we do MRI, our MRIs have better resolution and better accuracy to see the prostate, so we can draw the actual prostate. And because we can draw the prostate better, some people say when we do MRI guided radiation, it will decrease the side effects from the treatment. Yeah, so now what Dr. Metzger is saying, since with using MRI, we can see the prostate and the target in the prostate very easily, instead of treating all the prostate with radiation, which is the standard of care, why don't we treat only the area that has the cancer? If we do the YC and this is a cancer, that is possible, but it's not standard of care. It's probably something we'll develop in the future. But we know that today, if we treat
You're muted, Doctor. Dr. Osama, you're muted.
Sorry, have I been muted for a long time?
Yeah.
Long enough.
It's in the prenup.
What was the beginning of the lecture?
Oh, no, seriously, when was I prenup? When was I?
Just a joke.
It was
We were
just
talking about
10,
focal,
15 seconds.
yeah, focal
Oh.
treatment, yeah.
Yeah, for focal treatment, if we do the focal treatments here, we know that the cancer is going to come back in other areas. That's why today a lot of urologists are offering focal treatments to patients, but there is lots of debate whether this should be offered without a clinical trial.
Well, yes, and therein lies a problem. Things happen so quickly, and it seems so reasonable that you do something that makes sense, but it hasn't been proven. It's not standard of care. There we go. This business about rectal bleeding, I know we say it's 2 or 3%, but we get an awful lot of people talking about that. I think it
Really?
might be a little bit more prevalent than 2 or 3%, but I'm not
That's
sure.
interesting.
Dr. Osama?
Yes.
Okay, I have a follow-up question. Okay, because I had a chance to pull out I was referred to 2 gastroenterologists for my bleeding. And the first one, Dr. Chen, he says, no, do nothing. You have a very small laceration and it's okay. Then I was sent to another one, Dr. Shabib.
Mhm.
And Imad Shabib, he's Egyptian. I don't know if you might know him for some reason. And he recommended the laser treatment. So
Mhm.
I'm a little bit confused. The one says,
Yeah.
no, do nothing. And the other say, you might want to do a laser treatment.
Yeah, so it depends on what the doctors, again, so if you have a little bit of bleeding, you should not do anything. If the bleeding is a lot, you probably need to do something. Now, to do something, we usually don't start with a laser treatment up front. There are enemas, there are suppositories. Now, if the doctor comes in and see an active bleeder, then they are probably going to say a laser treatment for it. If the doctor does not see an active bleeder, so I'm not sure what each doctor saw or whether both of them did a scope.
Okay, thank you.
And there is a question. You showed TERP in the first slide as an input to the decision. What impact does the actually yeah, this is an excellent question. So what is let me just tell you what is a TERP. So typically we have the prostate and the bladder sits on the prostate like this. Sometimes as we get older, the prostate grows and become larger. And sometimes as it becomes larger, it grows and pushes into the bladder and start to grow into the bladder. So what the doctor, and the patient usually goes to the doctor, oh, I can't pee, or I wake up 5 times at night. So is there a solution? They will do an ultrasound or they do an MRI and they show like a large part of the prostate going into the prostate. So they tell the patient, oh, let's do a TERP, which is basically going through the urethra and cutting that excessive tissue. The impact that the TERP has on the radiation is that we should be very careful in patients who have a TERP, because after a TERP, the urethra does not heal as well. So we should be very careful in patients who have a TERP, not the standard radiation, the 40 treatments, the 20 treatments, but usually the high dose per treatment, the brachytherapy or the SBRT. We should be careful with the TERP.
My friend, be careful with the TERP after radiation therapy.
Absolutely, absolutely,
unbelievably a nightmare.
Absolutely, absolutely.
Even the one that's had seeds, the seeds keep popping out, and it just they almost are like lightning, and they light up, and it's very difficult. So yeah. Very
I'll take a question from Adam because his hand has been raised for a long time. Sorry about that.
Thank you, Doctor. I first of all appreciate the time that you're taking with all of us to answer our specific questions. I'm specifically going to ask about salvage radiation now.
Okay.
For me, it was I guess last September 21. I guess my PSA went back to 0.5. I had a prostatectomy in 2008. I had a back injury that then they asked me to do a PSA, and that's when they caught it. So it had already been at a 0.5 for probably that 8-9 months. They suggested salvage and hormone therapy. I haven't started it yet. Just been reading a lot of different things. The PSA is still, last time I looked, it was 0.6, kind of went 0.7, then 0.5, then 0.6. And just would like some input if you'd be so kind.
Have you had a PET scan?
No, they have not
Okay.
offered that. I'm at Kaiser.
Oh, you absolutely need to get a PET scan.
Okay.
A PET PSMA.
Okay.
Yeah, so you absolutely need to get a PET scan. So let me just
sorry. So before starting any treatment, get the PET scan.
Absolutely, yeah, absolutely.
Okay.
But let me ask you, so you had surgery a few years back,
Yeah.
right? And then your PSA was initially undetectable?
Undetectable. I guess the first time they saw it, because I went back and looked at my physical of 21, and it was at 0.5, but nobody said anything. And then when I had this back injury and it was recommended I get it again, it was at 0.5, and it became this huge because somebody saw it, I guess.
Yeah.
And then I was on a very personal note, I was at the door ready to get the injection for the 6 months, and I thought they were open till 5, and it was closed at 4:30. Otherwise, I'd have already started it. But then when that happened, I went, I want to think about this for a little bit and see what's up.
Now, if so, you've done the surgery, your PSA become undetectable, then it's increased, and it is now 0.5. And I would absolutely request to get a PET PSMA. And I'm happy, I'll share with you my email. Let me put it. So if you guys have any clarifications afterwards.
Thank you. Very kind of you.
So you can, I just put it in the chat, you can clarify the story, but typically I really think you will need a PET PSMA. Now, if your PSMA did not show any cancer, you absolutely need, if I were you, I would not delay the treatment. The only curative treatment you have at this moment is to do the radiation.
SBRT or IMRT?
In the post-operative setting, meaning in patients who had surgery before, SBRT is not standard of care. Yeah. And I'll take the question from the chat, and then I'll take to 2 patients raising their hand. The impact of prostate size on radiation, yes, over 100, we really don't like to do SBRT. We really don't like it. It's not an absolute no-no, but the bigger the prostate, the more likely you will have issues with urination. Bigger prostate, meaning you give it radiation. If it's gentle, it will be fine. But if high dose per treatment like SBRT, the prostate will swell, compresses around the urethra and block the urination. Now, there are many things we can do for large prostate. You can take a pill of finasteride, for example. For 3 months, 4 months, this will shrink the prostate by 25%. What's your opinion of SBRT on distant metastasis? I think it is not standard of care, but I think it's the future. If somebody have a distant metastasis, I think it's the future. I'm not saying it's absolutely experimental, but we need probably 10 years to absolutely say this is how we should do it. But I offer it all the time. It's relatively low risk treatment, and we think it's the future, but time will tell. Can you restate the standard of care of high-grade prostate cancer? High-grade prostate cancer, I'm assuming that you are talking about Gleason score 8, 9, or 10. The standard of care is either long-term hormone therapy, at least 12 months, but up to 24 months. And again, assuming no cancer in the lymph node, no cancer in the bone. And the radiation is any form of radiation. SBRT alone is not standard of care. SBRT combined with IMRT is possibly one option. Brachytherapy combined with IMRT is an option. IMRT alone is an option. And yeah, let me ask Dave.
Yeah, I'm a 72-year-old guy. I had a prostatectomy back in March of last year. But before that, I was diagnosed over the summer, and prostate cancer runs in the family. I had a PSA of a little bit higher than 52 at the time of diagnosis, so it was pretty clear I was infected with this cancer. We did a biopsy, and my Gleason score came out about half of 4+3s, and the other half about 3+4s. We did a PET scan. We did a bone scan, which actually showed negative. Ultimately, I did have a PSMA scan done at Kaiser. Unfortunately, they were unable to read it properly, as we found out later. So I elected to have a prostatectomy. And when I had the prostatectomy, about 6 weeks later, we tested the PSA, and it came back at 0.2. Okay. So we knew that there has been some microinvasion beyond the originally around the capsule of the prostate. Ultimately, when I took that PSMA scan over to UCLA, and they looked at it and they said, well, you know, we see stuff, two of your seminal vesicles are infected. I'm sorry, two of the lymph nodes were infected, and the seminal vesicles were also infected. So when they did the surgery, they did take out all the seminal vesicles. So after the surgery, and they
did not take the lymph node in the seminal vesicles
two of the lymph nodes were infected. Two of the 23 that they took out were infected, about 10%. And then, the seminal vesicles as well. So they took out that during the surgery, and they recommended the IMRT. So at the same time, they gave me an androgen deprivation therapy. Instead of going with the typical leuprolide, I ended up going with a GnRH antagonist as opposed to the agonist. I went with the Relugolix. And so I've been taking that, and as we speak now, my testosterone is actually below 10, and the PSA is undetectable. Although Kaiser only are sensitive to the 10th place. They don't go out to the hundredths, unfortunately. So, but at least it's less than 0.1.
It's okay. That's fine. You don't need the ultra sensitive.
Now, when it came to the IMRT, I was supposed to do like 37 treatments, but by the time I got to treatment number 17, I had developed such severe diarrhea and painful diarrhea that I had to discontinue.
So
I was not able to complete that the radiation, and I never went back on it because the doctors were saying, hey, well, you know, Dave, maybe we'll have to just monitor you in the future, but if something happens in the future, at least you haven't used up your bank of radiation, and maybe if something shows up, we can now do more radiation in the future to target a met if it does show up somewhere. I don't know, is that a rational line of thinking?
No, absolutely. I mean, a few things here. You know, I've never had anybody who could not continue their radiation. Never. I mean, I don't have this is my 4th year, so I cannot tell you in my 20-year experience. But in 4 years, never had anybody who cannot continue radiation. But, you know, we occasionally hear about these patients who are extremely sensitive to radiation. Maybe you have a genetic test, you have some genetic changes that make you sensitive, which is very weird. Do you have any diagnosis of Crohn's disease or ulcerative colitis?
No. Not Crohn's? You had Crohn's? I don't know. My wife is next to me here, reminding me of some stuff. In the family, my dad had prostate cancer. My brother, we did a genetic test for me. I apparently had that TMPRSS2-ERG, but I didn't have the BRCA2. I didn't have that.
I mean, have you had a PET scan after the surgery?
No, this was all before the surgery.
I mean, honestly, the approach is not unreasonable. You know, at some point in the future, they are going to get you off the hormone therapy. But
Right.
you need to know that you are not cured, and the PSA will absolutely increase.
Yeah, no, I realize I'm not cured. I know
And
they say that there is some kill because you're basically you're starving the cancer, but you're not killing all of
yeah,
it.
but so this is in your future, SBRT will play a big role. So although they are trying IMRT, which is to treat the full pelvis, right, which will expose all the bowel and the rectum, in the future, this is how I see things will going for you. Your PSA is going to increase, maybe 1 year, maybe 2 years, maybe 3 years, maybe 5 years. Hopefully it will never increase, but very likely it may. Right. And when it increases, you are going to get a PET scan. And I think that PET scan is going to show specific lymph nodes. But now that we know that your tolerance is radiation is poor, instead of doing IMRT, we're just going to treat those 2 lymph nodes or 1 lymph node with SBRT. And SBRT does not expose the bowel the same way. So your tolerance is very, very likely going to be excellent for it. And, we'll give you 2-3 years again. And then maybe at that time, your PSA will increase. We keep doing this.
Yeah, no, this is a marathon. This is not a sprint.
Yeah,
I understand that.
And he hasn't been on an ARI inhibitor yet, so as far as I know.
No, I'm not. Well, the only androgen inhibitor that I was on initially, they put me on the bicalutamide in anticipation of giving me leuprolide, but then I ended up not taking the leuprolide, so I was on it for like 3 weeks.
Oh yeah, Kaiser's the only one using that particular one, but you got a lot of bullets to put in that gun yet. Don't worry.
Yeah.
Yeah. Oh, my wife is asking me a question about lutetia. Is that something in the arsenal in the future? And
yeah, you are far from it.
Nobody knows.
Yeah, you are, which is good for you.
Maybe
that
copper, maybe not lutetia, maybe copper. Who knows?
Yeah, you are far from it now. Yeah.
Now, the other question that you mentioned that I should, at some point, if the PSA goes up to go do a PET scan, should it be a PET scan or should it be another PSMA scan?
Yeah, PET PSMA, it's the same thing.
Okay, I got you.
Yes.
That's the PET PSMA. Got it. Thank you.
Yeah.
Thank you very much. By the way, your lectures are excellent.
Of course. And now we get to my own patient, Mr. Fredrickson. I'm surprised to see you here. What are you doing here?
Well, I couldn't wait to see you. When I heard you come on, I signed up right away. Yeah, it's good to see you. It's been a while, and I guess that's good.
Yeah, I'm checking your PSA. You're doing great.
Yeah, it's been you and Hala decided no radiation in 2021 because of the numerous tumors, and put me on ADT hormone in March of 2021. Took me off of it in March of 2022. Testosterone came back 5 months later. PSA was undetectable, and I had blood just a couple of days ago, and the testosterone's 521, and the PSA is still undetectable. So I'm going into my 14th month. So
Dave, your case is not exactly like Terrell, but similar. Terrell, he had lymph nodes very high up. Including in your chest, right? Near the
in my throat, in my neck.
In the throat, like in the neck. So we decided, unlike you, we decided to treat you, but you could not tolerate the treatment. We decided, it's too much. We are not going to treat him. So very similar. It's been like, he's doing well. He got hormone therapy for a while, and now his PSA is still undetectable, despite he was not treated. So, but again, I told Terrell when I saw him, you know what? We will not treat you now. We monitor the PSA. If it increases, when it increases, we'll get another PET scan, and at 0.2 or around that level, Terrell. And if the PET scan showed a lymph node, which is the likely location of recurrence, at that time, the cancer that will show up will be the cancer that was resistant to hormone therapy, because the hormone therapy would have killed most of it, if not all of it. But there will be maybe some stem cells here and there cancer stem cells that are resistant. So they are like hibernating and eventually they will come up. But instead of like coming up here and here and here and here, we cannot target all of them. They will come up in one place, you hit it. And because hopefully the other cancer stem cells and the other cancer cells have died, we give him 1 year, 2 years, and then we keep doing the same.
Right, so 14 months is pretty good, huh?
Absolutely good, yeah.
With 521 testosterone and
Yeah,
PSA.
excellent.
I don't want you to take it personally that I haven't seen you. It's just that
I love not to see you.
I have a quick question.
Next one, by the way.
I have a quick question.
Yes.
I'm the person that had the radiation done and I was bleeding.
Mm-hmm.
And I went to 2 gastroenterologists, and one says do nothing, and the other one says do laser.
Mm-hmm.
And so, what's your opinion?
Again, you know, I'm not a gastroenterologist, but I can tell you that if the bleeding is continuous and non-stopping and there is a clear target to the laser treatment, maybe you don't have an option.
Okay, thank you.
Yeah.
Yeah. 41 years of practice, I would recommend the same thing.
Yeah. Yeah. Oh, you practice more than 41 years, Dr. Metzger?
Yeah. Hey, now, I have a question for you. You outside your building, there's a statue.
What statue?
Oh, outside one of your buildings, Mac told me there was a statue. One of my patients went up and Mac treated him, and he built him a statue outside one of your buildings. That's my statue.
Really?
I'm not sure what it is, but it's a big old thing that looks like, I don't know, you know, I don't know what it is, but yeah, Emory and that, we got a connection.
Yes, yes, yes.
We certainly appreciate your efforts tonight. You're just a great communicator. And
of course. What questions, guys? Anybody want to share their story? We have.
Yeah, thank you. Thank you.
I have a question about management. 84-year-old male. I had surgery in 2015, January. The Gleason was 9. There was protrusion from the prostate, but nothing in the lymph glands. The PSA subsequently was 0 for a year and then popped up to 0.1. Had radiation from February to May and no conventional treatment since then. The doubling rate for quite a while was 8 months. And then in 2019, in the fall, it accelerated to about 3 months, hitting around 10. And I was beginning an NIH study on immunology. It subsequently has leveled off and has been stable at 10 now for 2 years.
The PSA is at 10?
Yes.
Okay.
But I'm stable on a series of PSA is stable, and I've had a sequence of PSMAs, and very slow, if any, change. If you look at the kind of standard error measure, then in measuring the SUVs and comparing them pre to post, it's not a increase that one would have great confidence in. So here I'm essentially stable for 2 years at 10 with 2 spots, 4 PSMA scans, only 2 areas show up. One is rib 8 on the right side and thorax.
Okay.
So I'm not up at my age, I'm not optimistic, and I'm not jumping up and down, to put it mildly, about going through knowing what happens with your age, even though I'm pretty active, jumping up and down for the rigors of curative approach. But I am concerned about control.
Yeah. Have you, so let me just explain. Let me just reiterate. You had surgery, your PSA went undetectable, that it increased, then you had radiation, and then the PSA increased after the radiation?
Correct.
And then you had some treatment with hormone therapy, was it?
No, it's experimental agents for immunology for prostate.
Or immunology, and your PSA remains now stable at 10?
For 2 years.
for 2 years, and the PET scan showed 2 spots.
Right.
And have you had
right rib number 8 and and the thorax area?
Yeah. Have you had hormone therapy in your life?
No.
Oh, that's very interesting. You know, I mean, a few things could be considered. I mean, it seems like if things are stable and you're doing well and you have no complaints, you know, not to do anything is reasonable. But at some point, you still have so many things that could be done. You know, hormone therapy is possible if things accelerate, but also it would not be unreasonable to do SBRT to the 2 spots in your
Well, the
bone.
rib, yes, but how about around the thorax?
Where in the, what do you mean thorax?
Oh, gee, I don't have the reads of the hands.
Yeah,
They're little,
I mean,
very, very small spots that
yeah,
it's small to get in and do a biopsy of them.
yeah. I mean, even whether in the lung, there is no spot that I don't want to say there is no spot SBRT. Almost most disease sites, most locations could be treated with SBRT. But it's weird. Prostate cancer does not usually go to inside the lung typically.
Right. Well, there's spots. They don't say the lung, but above that. And we had a discussion about going to get a sample, but the people who do that, going down with a throat with their computer guided sort of thing, say, oh,
Yeah.
these spots are too small to really pick up.
Yeah, sorry, my answer is not great, but your case is very interesting. Lots of details.
Keep drinking the same tea you're drinking.
Yeah, that's amazing.
It is amazing. That's a great story.
Yeah. Samson?
Yes, Dr. Osama. I had prostatectomy in December of 2021.
Mm-hmm.
The pathology came back with a PT3B-N1.
Mm-hmm.
And my PSA has been going up. In January, it was at 0.13. And then most recently, it is been tested at 0.114, which may not be really a significant difference. But we are considering early salvage radiation therapy. I am due to take a PSMA PET scan this Friday.
Good.
The proposal is to have both radiation and hormone therapy. Is that standard of care?
Yeah, absolutely.
Well, the other question I have is with respect to the radiation, there is the spacer gels that are used. Do they use them
not in patients who have surgery?
After you've had surgery, you cannot use spacers?
No. So think about it. If this is the prostate and this is the rectum, they are wall to wall. We put the gel in the space between them. If you take the prostate out, you put the gel, it will just diffuse everywhere.
Right.
You know, you cannot. The gel is for patients who still have their prostate in.
Now there is. I've read in the prostate newsletter that the new standard of care is to have broad pelvic coverage.
Yeah, and this is what they will do for you.
To deliver more radiation than was done before.
Yes. So remember, you had prostate here, and the prostate was removed, and they found out that there is cancer in the lymph nodes. So not only you need to treat the area where the prostate was, which is called the prostate bed, but you need all to treat the lymph node chains around the prostate. And this is what they call the broad coverage.
What does that do to the side effects?
Honestly, the increased side effects from broad coverage, most of the toxicity or the side effects of radiation in patients who had surgery before is due to the treatment of the prostate bed where the prostate was. Adding the lymph node treatment will cause some mild nausea, no vomiting, mild nausea, diarrhea, loose stools, some rectal issues, but it's not severe. Most of these cases they will happen, but it's not going to be severe. You're going to push through it, and you are going to recover within weeks to a couple months after the treatment is over.
At the level of the PSA that I am at now, is salvage radiation increasing my chances?
Absolutely.
Because the standard has been to wait until it is 0.2.
No need to. No, you should not wait until 0.2. And unless they want to do a PET scan. Is this the goal? You're going to get a PET scan now?
I'm going to get it tomorrow.
Good.
Yes, let's get the PET scan and then treat based on the PET scan results.
And let's make an advertisement for the genetic component of prostate cancer in certain ethnic groups.
Absolutely.
There absolutely needs to be a genetic profile here, because there may be certain medicines that can be used that wouldn't ordinarily be used if the genetic the sequence is one or another. But this is a good time to advertise for the genetic component.
And I'll also, for Samson, Dr. Metzger is the expert on this. I will not, but also not only you should also be considered to be seen by a medical oncologist to discuss, I'm not saying to use, but to discuss the possibility of using, in addition to the hormone injection, to use the hormone pills as well, such as Zytiga.
Absolutely.
Yeah.
I have been, there is a study that is involving flutamide.
Oh, it's called GU008.
Yeah, this is the NRG study.
Okay. It's excellent. I have it open here as well, and I accrued patients to it.
Well, I haven't been able to locate anywhere that I could.
Let me tell you, Samson, don't stress about the study. A lot of the insurance companies will cover those pills even without a study.
Is that so?
So let me tell you an example. If a patient come to me like you, of course, we'll talk. I prefer that the patient get on the study, but if the patient does not want to get on the study, or they are not eligible, but they want to get the pill, usually refer them to the medical oncologist. I'm not telling you that you need the pill or you have to get the pill. I'm telling you, you need to talk with the medical oncologist. These pills are a little bit, they are not just pills. They have a lot of extra side effects that you need to talk with a medical oncologist to go over these extra side effects and do the balance between the risk and the benefit, so that to see if it's yours. But it seems to me like you are young and you have relatively aggressive cancer, so we have to treat it aggressively.
What are the pills? What pills are we talking about?
I'm sorry, put your information on our site and we'd be happy to include you in the prostate forum and help you.
Put what on the site?
Put your contact information on the chat, and Neil and I will get a hold of you and we can help move this along.
Okay.
Yeah, your email and your phone number, if you would, and you can address it to me, Neil Burr, or address it to the doctor, address it to Dr. Metzger, Charles Metzger, and he'll get your email
on the chat.
Just where it says to, yeah, you could just address it directly to him, and where it says to click on it, then click on Charles Metzger, and then he'll get your email without everybody getting your email.
This is a good time to remind everybody to click the
and your phone number, of course.
Click the little button to save all the chat, then you can review it.
Yep.
Okay.
Yep. But you got 3 dots right at the bottom where you're right.
In the circle. No, it's just 3 dots, sorry. These bifocals are hard to work with.
Okay. Samson,
No,
is
it
it
can
okay?
be.
You good?
Yeah. I'm trying to figure out how I'm going to send this, but go ahead. Go, I'm done.
Yeah, but you have
I
my
can give you
email.
another way. You want an email?
Yeah.
I can give you an email.
Okay.
Okay. I'm gonna put it in chat, give it to everybody. It's Prostate Forum OC at gmail.com. That's our email, prostateforumoc@gmail.com. And that way we can get your phone number and your email privately and respond to you.
Okay.
Okay. Thank you, Samson.
I believe Bruce.
Bruce
Thank
Harrington.
you.
Hi, I just sharing my story so far. You know, back in
Please do.
back in before August, I had a PSA of about 6 or 7. So we did the biopsy. Results came back 3+4 in half the prostate. I later sent it to Johns Hopkins and it came back 4+3. My PSA is still around 6. We just Wednesday went down to UCLA and talked to the urologist about removing the prostate and talked to the radiologist about radiating. Right now, it looks like I'm leaning towards radiation. We're going to do it looks like the 5 treatments, the SBRT and the hormone treatment for about 6 months. They're going to send my samples out and have the genetic testing done to see if it's a real aggressive form of the cancer or not. They did do a mouth swab to, I guess they can determine if I am prone to having problems with the radiation treatment.
Yeah.
So they're going to do they got the Meridian machine down there. So that's where I'm standing. I'm really leaning towards the radiation rather than surgery.
Yeah, I mean, you both options are great for you. Whether surgery or radiation, they are both good options. They do have different kind of side effects, but they both have side effects, but different types of side effects. Typically, there is a little bit more leakage and a little bit more sexual dysfunction with surgery, a little bit more urinary retention, blockage of the urine, and diarrhea with the radiation. Now, one thing that's important for you is that if you need radiation, you absolutely need 6 months of hormone therapy, 4 to 6 months of hormone therapy. With surgery, you don't need hormone therapy.
Okay.
You know, there is really no right or wrong answer for you. Of course, I know the team, the radiation team in UCLA. I don't know who's your doctor, but they're very, very good. They're actually excellent, and they are leading the research on the Meridian MR guided radiation therapy.
Okay.
How about adding the ARI to the Lupron and then the radiation? Some of the preliminary stuff looks really good.
Sorry, what did you say, Dr. Metzger?
Adding an ARI to the mix with the radiation and the Lupron. Some of that preliminary stuff from Europe really looks good.
Yeah, I totally agree, but you know, it seems like sorry, I may have missed it, but he seems like he have early stage prostate cancer.
Yeah.
Not high risk, right? Not high risk.
No. Well, medium, but the high risk on the medium.
Yeah, unfavorable intermediate risk.
Right.
How much 4+3 there is? It could be. Yeah, I was just thinking out loud. We're getting a lot of stuff from Europe saying,
yeah,
adding more and more. You know.
Yeah, for patients who have high risk, absolutely, abiraterone is or Zytiga pills.
And UCLA has a clinical trial for that.
Oh.
They have a clinical trial for everything. Driving the freeway, they clinical trial for that.
Yeah. Bruce, do you have any specific questions?
I guess my main concern is leakage after the radiation, and secondary is the sexual component.
Yeah,
that's my real concern.
So there's no treatment has zero side effects, of course, but to have serious leakage after radiation is 1%. But to have occasional leakage, especially when you get the urge to urinate and you don't get to the bathroom in time with radiation, is around 5%.
Okay.
Yeah, sexual dysfunction, you know, especially with these MRI guided LINAC, we still have not exactly defined, but the more you are able to treat the prostate only without damaging the nerves and without damaging the bulb and the penis, the less likely sexual dysfunction. But I usually tell my patients in general, if you have good sexual function before the radiation, 1/3 of men will have good sexual function after. 1/3 of men will have good sexual function, but they need Viagra, and 1/3 of men will lose that sexual function. But remember, you have 6 months of hormone therapy. You will not have any testosterone, so no sexual function and no libido. And after that, you need 6 to 12 months to get your testosterone back. So it's extremely unlikely that you are going to participate in a sexual intercourse in the next year or year and a half.
Okay. Okay, thank you very much. Very interesting listening to you talk. Thank you very much.
Of course. Adam, question?
Oh, here I come. I think. Here we go. Do I have a camera yet? There I am. Hi. So just a follow-up. I almost lowered my hand when you said the 6 months of hormone and the radiation. The numbers, are they that much different? I was told or read or something that it's a 70% success rate if you don't do the hormone therapy and an 80% success rate if you do. So if you did it without the hormone therapy, is that not the way to go?
Remind me the case.
I'm sorry, salvage.
Salvage. What are the details? What you?
0.5. It came up to 0.5 about a year and a half ago. I think now it's 0.6. Last time I did it. They said the sexual function after the first year or two would be all it would get, and I got much better. I don't have leakage. So all of these things are going to decrease again, right, with radiation?
Leakage, the chance of leakage in your case was recently a very nice report. It's severe leakage 1 to 2%.
Okay.
But some leakage is going to be around 10% or even like close to 15% actually for you.
Okay.
Some leakage, but severe leakage is not very common.
And sexual functionality?
On hormone therapy is going to go away.
Oh, no, I mean after the couple of years.
Yeah, so you're going to take, it's going to take, if you have good, do you have sexual function now?
It's not the greatest, but I can make it work. I don't need pills. I don't need the shot anymore.
Yeah. I think you will at least need the pills after the radiation.
Okay.
At least, and this may not work. So you may need to get to the next level of intervention, which is injection.
Yeah, we did the injection's awesome. I did that in the beginning.
Yeah. So, but the good news with radiation is that if the injections worked before, they will continue to work. The radiation does not affect the success of the injection.
Okay. And then is that percentage right? There's only a 10% difference between
Let me show you the data, and then let me show you the data. This is a French study that was published like maybe last year. But while I'm showing you the data, I want to show you how we look at these studies. Okay, I will share my screen.
While you're doing all that, thank you again for your generosity with your time.
Of course. So let me show you here. So these graphs are very interesting for you guys to just know how. Let's focus just on this graph A, the panel A. You guys can see it?
Yes.
Okay. So you see there are the axis here is time 0 is when you get the radiation, and then 12 months, 24 months, 3 years, 4 years, 5 years, 10 years is here. Okay, so this is as time goes, and this here progression-free survival, meaning at each time point, what is the chance that you are alive without recurrence? And we have two graphs, radiotherapy alone, this is salvage, in the blue, and radiotherapy plus 6 months of hormone therapy in the red. And as you can see, 10 years from today, radiotherapy plus hormone therapy has a chance of about 70% of being alive without progression. Radiotherapy alone has about 55 to 60%. So there is, as you said, exactly, there are about 15 points advantage to getting those hormone therapy.
Okay.
Yeah. Now, we know that not all patients benefit the same way. So whether you benefit or not, it's not clear. But your PSA, honestly, although it's 0.5, people will tell this is not a very high, but 0.5 is considered a relatively high PSA.
Right.
Yeah.
Okay. Thank you very much again. I appreciate it.
You are very welcome.
Doctor,
Yes.
can I ask a follow-up?
Yeah, of course.
Kind of in a, I would call this kind of a risk management question. Okay. I had surgery 9 years ago.
Okay.
It took 3 years for my PSA to get to 0.016.
Okay.
So it cracked the undetectable at 3 years.
Wow, it's remained undetectable for years?
But no, for 3 years. And then it started going up. I'm 9 years out from surgery. It's now at 0.45.
Okay.
With a PSMA PET CT that didn't find anything. Okay. So we may do another one, and it stopped dead. My PSA stopped dead for 6 months, didn't go up. So we're thinking of another PSMA PET in April, or I'm thinking of waiting a little longer to get a better chance of a PSMA PET scan finding specific points. Treat. It goes against the idea of letting cancer get a better foothold. You don't want to wait too long. So I call that risk management. So right now, my thought is to wait a little longer, let PSA get a little higher to get a better chance of a specific treatment location.
Yeah.
So it's sort of a risk management issue to balance. Just wanted to get your.
Yeah. So what you are talking is
I'm 77.
Yeah.
Okay? Good health otherwise. So it's not like I'm 60 or 55 or something. So and my doubling time was like 2 years lately. So all those factors, I feel comfortable waiting a little longer to try to get a treatment spot.
Yeah, absolutely. It's very reasonable, to wait and see, especially that we call them the PSA kinetics, which is how fast the PSA has been increasing, the doubling time specifically. PSA doubling time of 2 years is very encouraging. Now, it's a very debatable thing in medicine whether how long we should wait. Should we wait until a PET scan shows something to intervene, or in your particular case, many people will say even if the PET scan is negative at a PSA of 0.5 to irradiate where the prostate was, because most likely the cancer is in that area. But this is a very debatable thing, and waiting a little bit is fine. If your PSA is 0.5 with a doubling time of 24 months, I think you are safe to wait a little bit.
Okay, very good. Thank you. I appreciate that. By the way, I'm inquiring now if we do another PSMA PET, I want a second read at UCLA, because those are the experts. They've been doing it.
Absolutely. UCLA together with UCSF, they basically brought PSMA to the country. and led the FDA approval process.
Right. Well, thank you very much for your thoughts.
You are very welcome.
Can I ask a question?
Of course.
Sure. Go ahead, Samson.
Are there subtle differences between the ultrasensitive PSA and the PSA, which is not ultrasensitive?
Yeah. So in your case, your PSA is, if I remember correctly, 0.12 now.
0.14.
Yeah. So you don't need an ultra-sensitive test. Because
that was an ultra-sensitive test.
Yeah, but even if you get the regular one, because it's above the limit of detection, then you will get the same results. For you in particular, it's irrelevant because you have exceeded the limit of detection of the ultra-sensitive assay.
Which is what?
So different some tests are 0.006, some tests 0.01, some tests 0.014. It's almost all in the 0.0. Once you are 0.1 or higher, it's irrelevant.
Okay.
Yeah, you don't worry, should not stress about it.
Okay.
Yeah.
Doctor, can I ask one more thing?
Yes, please.
Strictly curiosity here. You answered my question about a TERP and radiation as an input to your what you would do to treat. I'm just curious because I had a TERP and then I had surgery years later.
Okay.
Did the TERP have any impact? Did the TERP have any impact on the surgery result? Is a TERP a problem for surgery? I'm just curious about it.
So it does not impact the oncologic outcomes, meaning it does not cause the cancer to come back or spread. But sometimes think about, remember, with TERP, you go through the prostate and you cut a big part of the prostate and you cut it where it's close to the bladder. Sometimes when you have a big TERP, it becomes, and you do the surgery, you cut the prostate out and you want to bring the bladder and bring the urethra and connect it. Sometimes when you have a big TERP, it may affect that connection, that we call it the anastomosis, and will increase the chance of leakage after the surgery. But it does not necessarily make you increase chance of recurrence or give you detectable PSA, but mostly leakage.
Yeah.
Okay.
Let me speak to the surgical aspects of that. It's a friggin' nightmare. The scarring from previous surgery or the scarring from radiation is a nightmare to then try and do a TERP or any kind of procedure on that bladder neck. It is just very, very difficult.
Absolutely.
Tissue does not behave like regular tissue. You cut through it and all of a sudden you got 6 blood vessels going. It is really a mess. So we like to avoid those things as surgeons. Yes.
Okay. But if you had the TERP first and then surgery, no radiation?
Well, it depends on whether they got near the capsule. If they got near the capsule and there's scar tissue, then a radical prostatectomy is very difficult. Radiation probably doesn't matter because you're treating scar tissue, not cancer. So it probably doesn't make any difference. Boy, it's just a nightmare as a surgeon.
Okay.
Doctor, I have a question, doctor.
Hey, how you doing?
I'm fine, doctor.
I haven't seen you in a while.
Yes, sorry. I've been.
Aloysius.
Yes. I have a question to ask you, doctor. I went through, I had just a dot on my prostate on the left base, which turned aggressive. So, last year I had a, focal cryoablation. I mean, they froze that area of the left base. And now I'm due for a biopsy in October, to see how the cancer is doing. Now, just my question is for the future, if the cancer came back or something, what is the best option for me? Because I had a 4+5. It turned aggressive, but I'm in good health. Otherwise, everything was fine. I feel I'm in perfect health. So what do you suggest if, in terms of radiation, if I go for that option?
Yeah. So it's not typical to do cryotherapy in patients who have high-grade disease. It's not typical. This is not a typical approach. But if you have had it already and we are following you with the PSA, let's say you have a recurrence, you have two options. You can do surgery or you can do radiation. Now, the radiation will depend on the Gleason score at the time of recurrence. But let's say you have high Gleason score again, then you will need radiation therapy plus hormone therapy. The hormone therapy duration will depend on the grade of the disease, 7, 6 months, 8 or higher, 18, 24 months. Now, the radiation approach, we really are unable yet to tell in patients who had prior cryotherapy whether we can do SBRT or brachytherapy in them. So I think to be safe and to be conservative in order to spare you possible increased side effects from high dose treatment, your treatment is probably going to be just IMRT with hormonal therapy, which is fine. It's not a bad thing, but we just, in patients who had prior HIFU or focal therapy or cryotherapy like you, we prefer to be gentle on the prostate. IMRT, maybe 44 treatments or 20 treatments or 35 treatments, gentle treatment with hormone therapy whose duration would depend on the grade of the disease.
Thank you. Thank you.
You're very welcome.
Yeah, he had targeted cryotherapy by Dr. Marks at UCLA.
Okay.
He's our banner patient. We're watching him with great anticipation.
Yeah, it's a big debate actually. UCSF has a debate next week on Monday, I think, on the use of cryotherapy. As you know, it's a lot political, and it's a lot of fights between radiation oncologists and urologists for this. I think time will tell in the future that we can do more focal therapy than what we do now. But it's a matter of time. Somebody asked me about the SBRT to the bone mets. I told them, there's not a lot of data, but I do it even without data, and it's reasonable to do, but we need time to prove it. I think the same thing with focal therapy.
Absolutely. My guess is focal therapy is going to be more useful in the future when it gets more established. It just
Absolutely.
makes a lot of sense.
It's a matter of time. It's just a matter of getting those data and the clinical trials showing the proof.
Yeah. Well, gee, I think are we out of questions, Neil?
Does anyone have any more questions?
I have a question.
Doctor, I want to thank you.
Hi, thank you for the wonderful lecture and the responses, Doctor. When is an ideal time to give hormone therapy with radiation?
The duration of hormone therapy is usually dependent on how aggressive the cancer is. If in patients who have their prostate in and they have Gleason score, like intermediate risk prostate cancer, hormone therapy is 4 to 6 months. Patients who have high risk prostate cancer, hormone therapy between 18 to 24 months.
Actually, my question is, when do you start the radiation?
Sorry.
It was my
adjuvant or neoadjuvant.
Yeah. Right. Now this became a question in the past couple years, and if you still have your prostate in and you're getting radiation to prostate only, You are not treating the lymph nodes. The most recent data suggests that most of the hormone therapy should come after the radiation therapy. So usually patients come to me sometime during the radiation. I give them the first injection.
Adjuvant.
If you are treating the prostate only, most of the hormone therapy should come after the radiation. Now, if you are treating prostate and the lymph nodes, which is usually what you do for more aggressive cancers, there is some data to suggest that maybe giving 2 months before the radiation may have some benefit. And we believe it's something related to the immune system, but we really don't know how that works. The evidence for that is not very strong. Macroach actually is a big proponent of this idea that if you are treating the lymph nodes, give them a couple months before the radiation.
That's
now, one important consideration also always think about is patients who have very large prostate or have urinary issues that we believe is due to the cancer progression. These patients should get hormone therapy before the radiation, 2-3 months, because the hormone therapy will cause shrinkage of the cancer, shrinkage of the prostate, improvement of the urinary function, such that they can tolerate the radiation better.
You had talked about SpaceOAR. Could you talk to a linear accelerator? How does that help versus a SpaceOAR?
So the linear accelerator is the machine of the radiation. So it has nothing to do with the SpaceOAR.
Does it give more precision?
All the radiation machines are called linear accelerators.
Oh, okay.
Every linear accelerator can develop a certain technique of radiation, such as IMRT, for example, is a technique of radiation delivered by the machine, which is the radiation.
Why do some radiation oncologists like to use a SpaceOAR and others don't?
I don't know, honestly. The data does not support the extensive use of SpaceOAR. The data the data that was used to get the FDA approval for the SpaceOAR is extremely weak.
Right.
But it's used.
I'm asking, you're the expert, that's why I asked.
I know. I mean, SpaceOARs, generally well tolerated, but you have occasional issues with some rare serious toxic side effects from SpaceOAR placement. Very rare, but they do happen. Yeah, I mean, I have been in practice for 4 years. I've seen 2 patients who've had terrible damage to the rectum from SpaceOAR placement.
What about extracapsular extension? How often does a SpaceOAR, stop the treatment of the cancer?
So if patients who have extracapsular extension near the rectum, we should not be using maybe we should be very careful in using the SpaceOAR.
And how do you know if there's microscopic? I mean, I'm just asking if it's microscopic or not.
I mean, if it's microscopic, we do not see it, right?
Yeah, of course.
It says so. Some findings on the MRI, if the cancer so extracapsular extension is when the cancer visibly go through the capsule, right? It's like we can see it's extending through the capsule. However, sometimes we see that the cancer is pushing on the capsule, not penetrating, is pushing. We say this is suggestive of microscopic extension.
Doctor, I have a question to ask you. Is there any, any latest developments in prostate cancer where, you take any tablet or something or a shot which can, disrupt the cancer? Is that something you're aware of?
You mean vaccine? When you say shot, you mean vaccine?
Vaccine or something like a capsule or a tablet or something?
No, I mean, there are lots of advancement all the time. The vaccines actually are not very successful for prostate cancer, honestly. They have tried, I don't think, like vaccines and immunotherapy have not been successful at all for prostate cancer. You know, the most recent, the things that got a lot of attention in the last couple of years is lutetium. And since lutetium, I think there's always things happening, but no major breakthrough yet, like recently.
Now, what is that, a hormone? Lutetium?
No, the lutetium is a radiation therapy, is an injectable form of radiation therapy. But today, it's only for advanced prostate cancer who is no longer responding to hormone therapy. Unless it's on a clinical trial, it's a different story. But the FDA approval is for advanced prostate cancer who's no longer responding to hormone therapy, and it is providing you know, very excellent results for those patients.
That's only true in the U.S.
Huh?
That's not true in Europe. That's not true in Europe. Only here.
What do you mean?
In Europe, you can be first time diagnosed and get.
I see what you mean.
Gentlemen, we're approaching 9 o'clock and we need to say good night. Doctor, I want to thank you for a very stimulating presentation.
You're very welcome.
One that's really challenged a lot of our assumptions about radiation. And we're looking forward to having you back again.
Okay.
We're looking forward to seeing everyone again at the newly diagnosed group or at the advanced group. And with this, we thank you for attending and say good night. And thank you again, Doctor.
Bye-bye, guys. Have a good evening.